Perfect. So I think we can start. Good afternoon, everyone. Welcome to, once again to our Seasonal Risk Forum that we organize on the second day of the IRCAD course here. Today we will have a first part around mid-carpal instability. We will have some interesting discussion around this topic, which is quite controversial. First lecture by Christophe with Andrea Azzei and Gustavo Gomez, who will be online. And a second part around proximal scaphoid reconstruction in a young patient with Jeff Yao. It will be and Ali Havit from Turkey. So as usually, Lorenzo will manage the chat. For people who are online, feel free to ask any question online. We will answer the questions, and here, please don't forget, if you want to ask questions, to switch on the mic. So.
Okay, thank you, Alam. So we start with the idea about the treatment of mid-carpal instability, and I'm going to explain you how I came to describe the arthroscopic treatment for volar mid-carpal instability and the importance of this kind of course, because you know that this kind of course is a real brainstorming between you, surgeon, and us, expert but surgeon too, and we exchange ideas and we have some ideas. So we were in Shanghai in 2012, and with Mark Baratz, we cleaned the synovium on the volar mid-carpal joint, and we never do that classically, and we discovered this complex, as you see here, and the ligament knot here between the ulnocarpal ligament, the extension of the long radiolunate ligament, and the radioscaphocapitate ligament, and which this system allowed me to understand the origin of the mid-carpal instability and the rupture of the attenuation of the arcuate ligament could be a problem and a reason of the sliding of the second row on the first row, because we lost the extrinsic palmar ligament. So the idea is to make a suture as for the classic dorsal repair. So you see, here, of course, we are in traction, and but you see when I touch with my needle, you see that there is a distension of the ligament, and I have to wait 1 year, because it's a rare cases, the volar carpal instability, to find this kind of problem. So we clean the synovium and with a shaver in mid-carpal, and we see very well the tear of the volar carpal extrinsic ligament. So the idea is to open and to make a suture between the three different parts. So I put my needle with suture, as I use for the dorsal capsuloplasty, and you see the free part of ligament on the distal and proximal, and with forceps by the radial mid-carpal portal, my scope is in ulnar mid-carpal portal, I retrieve and pull out all the suture in one time, because it's not as complicated. I make an outside knot very easily, and I pull down the volarly and the knot in order to reconstruct and to have this kind of principle of suture. And you see the drawing explaining what I would like to have. And at the end of the operation, the tension is really better than before. And this guy was the first. I have a series on press published by Jean-Baptiste de Villeneuve and Lorenzo Merlini. And you see, he has this kind of problem with the real clank. We can hear this clank. On the X-ray, almost normal, small VZ, and you see the result after 14 months of follow-up. You don't have the tricuspid catch-up clone, no pain, normal ROM, and the VZ disappeared. So the discussion is very long because it's very complicated to discuss about the mid-carpal because it's a rare lesion, in fact. And you see the shrinkage has been described for the arthroscopic technique, but in fact there is different possibilities. So in conclusion, the palmar mid-carpal instability is rare. The treatment is still controversial with the stiffness transform, and the principle of the arthroscopic volar capsulo ligamentous repair seems a really simple and reliable technique, convenient for the patient, and the result I obtained with this technique is very interesting. Of course, long-term follow-up and large surgery are necessary, but that is an idea. And the most important is to understand that during this kind of course, we can discuss together, exchange ideas, and find sometimes solution. Thank you very much.
Thank you, Christophe. I think we will let the discussion at the end. Thank you. So now we will discuss about the diagnosis, the pathogenesis. Sometimes it's very difficult to diagnose mid-carpal instability. And we have Gustavo Gomez from Buenos Aires. He prepared a very nice lecture to try to make the understanding easier for everyone. I think we have Gustavo, maybe.
Great. Okay. Thank you for the invitation. I'm very happy to be here among all of you. I can see many friends and masters there. So I'm Gustavo Gomez Rodriguez from Buenos Aires, Argentina. First of all, I would like to say that this is one of the most complex and difficult topics, as Christophe Mathurin said, not only to understand, but also to explain, mainly because there is not yet a very clear understanding of this pathology. In 1981, Leachman introduced the name mid-carpal instability. He explained the functioning of the carpus as an oval ring formed by two mobile links, the mobile trapezioscaphoid articulation and the rotatory triquetrohemate joint. He mentioned that the disruption of this last link was the responsible for mid-carpal instability, highlighting the participation of the triquetrohemate ligament. However, author concludes, we have been unable to recreate the exact entity under experimental conditions in laboratory. In 1993, he introduced the name palmar mid-carpal instability and once again highlights the failure of the triquetrohemate ligament as necessary to generate mid-carpal instability. In 1994, Wright and colleagues adds the concept of palmar, dorsal, and combined mid-carpal instability, and authors proposed the term carpal non-dissociative, carpal instability non-dissociative. Then in 2008, Mark Garcia-Elias brings us some light to understand better the etiopathogenesis of the mid-carpal instability. So let's try to understand this. Palmar mid-carpal instability is the most common form and also named in many ways. As we all know, volar ligaments tends to go from the radius and the ulna to the capitate, with the radial and ulnar arms of the arcuate ligament. But let's focus just for a moment on the triquetrohemate capitate ligament and the scaphocapitate ligament and the SDT ligament. When a normal wrist moves from radial to ulnar deviation, the proximal rod moves smoothly from flexion to extension. This is a normal wrist under fluoroscopy. It is apparent that At the two extremes of motion, the proximal row is flexed or extended as a consequence of a specific joint compressive forces being directly applied onto the scaffold in radial deviation or onto the triquetrum in ulnar deviation. To understand better what happened in a normal wrist, I like to explain it as a timeline during ulnar deviation. When the wrist goes from neutral position to ulnar deviation, the STT ligaments increase in tension, inducing the progressive extension of the scaphoid. The capitate continues to rotate, so the scaphoid capitate ligament that is inserted distal to its center of rotation increases in tension too, adding a more extension moment to the scaphoid. Meanwhile, the proximal pole of the capitate rotates radially, adding tension to the triquetrohemate capitate ligament, which generates extension on the triquetrum. The scaphoid transmits extension to the lunate through the scapholunate ligament, and the triquetrum transmits a little bit of extension to the lunate through the lunar-triquetrum ligament. Finally, the engage between the hamate and the triquetrum occurs, generating an extreme extension of the entire row of the carpus. In mid-carpal instability, all of these ligaments are hyperlax, so the moments that depends on the ligaments are delayed in our timeline. The smooth transition of the carpus during ulnar deviation is lost. So, when the wrist goes from neutral position to ulnar deviation, the STT ligaments don't increase in tension, so nothing happens to the scaphoid. As the wrist continues to ulnar deviation, nothing still happens, until maximal ulnar deviation when compression forces of the triquetrohemate joint generate a sudden extension moment to the proximal row. Such an abrupt rotation of the proximal row relative to the radius is perceived as a clank. The entire proximal row suddenly reduces into the extended final position, taking the distal row with it. Now I would like to focus on the dorsal radiocarpal ligament that goes from the dorsal aspect of the radius to the dorsal aspect of the triquetrum, as you all know, and as you can see here in this cadaveric dissection that we performed in our lab. In a normal situation, this ligament is very important to avoid the flexion of the proximal row. Therefore, when this ligament fails, this first row goes into flexion. So patients with palmar midcarpal instability have the first row in flexion during neutral position, and it goes to neutral alignment during ulnar deviation due to the extension produced by triquetrohemate engage. And this is the reduction of the dorsal deformity that you can see in these patients during ulnar deviation in physical examination. As you can see here, again, under fluoroscopy. Now let's talk about dorsal midcarpal instability. It's rare, and it's also called in many ways too. To explain it, I would like to focus now on the scaphotriquetral ligament, the deepest and most proximal portion of the dorsal intercarpal ligament that connects the triquetrum to the scaphoid. This ligament closes the scapholunate socket from behind as a dorsal labrum, giving dorsal containment to the proximal pole of the capitate. So, when this ligament fails and we have some laxity on the long radiolunate ligament, the capitate subluxates dorsally over the dorsal edge of the scapholunate socket while the proximal row is in extension. In this case, the proximal row remains normally aligned in all raised positions except in full ulnar deviation when the proximal row suddenly extends, as you can see here under fluoroscopy. And finally, we have the combined midcarpal instability. Asymptomatic most of the times, this form of clanking is frequent among teenagers. It's very similar to palmar midcarpal instability, but adding an increased mobility of the radiocarpal joint with an abnormality flexed and ulnar-translocated proximal row in radial deviation and abnormal extension with capitate dorsal subluxation in ulnar deviation. The model of carpal motion described by Wolf as the mooring line concept is very useful to understand what ligaments are involved. So, Dr. Atsei and colleagues proposed that the ligaments that fail in palmar midcarpal instability are dorsal at the radiocarpal joint and volar at the midcarpal joint, while the ligaments that fail in dorsal midcarpal instability are dorsal at the midcarpal joint and volar at the radiocarpal joint. So then, in palmar midcarpal instability, STT and scaphocapitate ligaments are affected in the radial-sided subtype, and the triquetrohemed capitate ligament is affected in the ulnar-sided subtype at the mid-carpal joint, while the dorsal radiocarpal ligament is affected at the radiocarpal joint in both. In dorsal midcarpal instability, scaphotriquetral ligament is affected at the midcarpal joint, and the long radiolunate ligament is affected at the radiocarpal joint. In physical examination, we can see a carpal supination and volar sac of the wrist related to a volar translocation of the ulna column of the wrist, producing also ulnar supination, carpal supination, and is confirmed by an increased pisostyloid distance. A dorsally directed force applied on the pisiform correcting the volar sag may alleviate the pain by supporting the volar ulnar side of the wrist and also reducing the carpal supination and flexion of the proximal row. The mid-carpal shift test described by Leachman is the specific provocative maneuver. The wrist is ulnarly deviated while maintaining palmary directed pressure. There is a clanking as the wrist approaches to full ulnar deviation. The anterior drawers test can show us the open mouth sign described by Mark Garcia-Elias, demonstrating the laxity of the STT ligaments. Volar subluxation of the capitate indicate laxity of the STT and the scaphocapitate ligaments and the triquetrohemed capitate ligament. Same in anterior-posterior X-rays with forced ulnar deviation can show the open mouth sign showing STT laxity. Posterior drawers test can show the dorsal subluxation of the capitate and thus the laxity of the scaphotriquetral ligament and the long radiolunate ligament. Neuromuscular rehabilitation with proprioceptive exercises and muscular strengthening of the FCU and the ECU is particularly effective. A three-point dynamic splint can push dorsally the pisiform and provide pain relief and improve function. If non-surgical treatment is not effective, we can follow the gradient system described by Hargraves, including soft tissues procedure, thermal shrinkage, and bone fusion. Thermal shrinkage seems to have good results, although we have to be very careful to the disturbance of the proprioception and the complications that this technique presents. Shang-Ding and colleagues proposed this algorithm in dynamic conservative treatment, in static and reducible soft tissues procedures, and in irreducible four-corner fusion, going to a new step after failure of the previous treatment. As regards soft tissues procedures, Leachman focused on the triquetrohamate stabilization in his first and second paper. Then Mark Garcia-Elias tries to reconstruct both the triquetrohamate and the dorsal radiocarpal ligament. Then in 2015, Leachman starts to focus on the dorsal radiocarpal ligament, same as Professor P.C. Ho and von Schroeder. And in Leachman's last papers published this year, authors conclude that dorsal radiocarpal ligament plicature is effective for the treatment of the palmar midcarpal instability, reserving the closure of the poireal space for the treatment of dorsal midcarpal instability. As regards bone fusion, I want to mention just this paper with Mark Garcia-Elias between the authors. They concluded that the radiolunate fusion seems to be superior to the triquetrohamate fusion, since the radiolunate fusion conserves better the dart throwing motion. In conclusion, it seems that throughout history, attention has been moved from the triquetrohamate ligament to the dorsal radiocarpal ligament. It may be perhaps because we are now understanding that mid-carpal instability is actually an instability of the proximal row. So shall we change the name? Thank you very much.
So I have to start with this lecture telling you about current perspective and controversies. At least I'm happy that I'm not in full controversy against Gustavo, that described very nicely the concept that recently we published in the book of the FESH instructional course. And so I have to thank Carlos Herraspalo, Pedro Delgado, Ricardo Lucchetti, and Marc Garcia Elias, most of all, for the insight they gave me to develop the concept I'm very happy to share with you this afternoon. So, present classification of carpal instability was proposed by Mayo Clinic in the early 90s. And among the different forms, we recognize those which include a dissociation of proximal row and, on the other hand, the so-called non-dissociative carpal instability, in which the proximal row is called the intercalatic segment move has a single unit. So all these non-dissociative instabilities include a very large group of carpal dysfunctions in which the key feature is the integrity of bone and the intrinsic ligament of the proximal carpal row. So we recognize three instability patterns: the dorsal, the volar. A subtype is defined according to the location of the kinematic abnormalities at the radiocarpal joint. They can be palmar, dorsal, or ulnar, and is actually well known as the carpal translocation. The other subtype is the mid-carpal subtypes, in which the abnormalities is at the mid-carpal level. So, as Gustavo already stated, the paper that introduced the concept of mid-carpal instability was proposed in a condition in which the disruption of the ulnar side of this ring, of the ring concept, is resulting in a mid-carpal instability. According to the abnormalities on the kinematic, the paper of Lichtman is actually misleading, because it appears to focus on the kinematic dysfunction at the mid-carpal joint level only, assuming that the radiocarpal kinematics remain unaffected. However, the proximal carpal row tilts relative to both the radius and the distal carpal row, and that implies that the dysfunction occurs at both levels, radiocarpal and mid-carpal level. There are many biomechanical clinical studies that confirm that the actual pattern of the so-called mid-carpal instability results from the ligamentous disruption at both levels. So actually what we commonly define as mid-carpal instability is actually a combination radiocarpal and mid-carpal instability. So the mid-carpal instability proper should be a condition very, very uncommon. For instance, when we have lax mid-carpal ligaments after radioscapholunate fusion or prosthesis, or isolate carpal dislocation when the proximal carpal row remains normally in line, which is a very, very uncommon condition. So we have plenty of different definition, very confusing, and starting from the basic misunderstanding of the definition of Lichtman, and still nowadays we still have a gross lack of understanding of the pathomechanism. So we have those several conditions which are labeled as separate clinical entities, but in fact they are only different aspects of carpal instability. So if we get back to the early years of the literature about this subject, we found that the group Mayo, in the paper by Wright, they defined the proximal the carpal instability non-dissociative as a proximal carpal row instability. So we believe that we need to revise the current definition of mid-carpal instability and use a more kinematic sound definition of proximal roll instability. We have different causes, development or post-traumatic. We have these instability patterns, and this is the clinical appearance of most of these cases. The anterior mid-carpal clunking can be produced by the patient himself, and this is a quite rare case by Margaret Elias of the palmar mid-carpal clunking that occurs in radial deviation with a dislocation. You see here with the dislocation of proximal pole of the scaphoid. So another improvement that was related to the application of the arthroscopy is related to the evaluation of the ulnar carpal ligament complex, because arthroscopy in this case showed us that the ulnar carpal ligament were quite lax, and actually in most of the descriptions which were made after biomechanical studies, the ulnar carpal ligament are very rarely studied. Let's see what happened at the level of the dealing with a volar proximal roll instability. We see the ligament affected, and the concept of the mooring line is very nice, because it's easy for you to understand the location of the ligamentous damage when you consider those couple of mooring lines that are keeping the proximal row in place. Another tricky condition is that caused by the supination, carpal supination of the proximal row, which is quite common in volar proximal row in instability. And we believe this is related to the involvement of the ulnar carpal ligament. You see here the reduction can be restore this problem. So if we have to consider all those conditions that were labeled as a palmar mid-carpal instability, we see here that we have many conditions: snapping wrist, anterior medial mid-carpal instability that can be mostly defined are ulnar-sided volar, ulnar-sided proximal row instability, or the anterior mid-carpal instability, which may be called a volar radial-sided proximal roll instability. This is a typical case you see of the patient, and we already see the definition. These are the radiographic findings that correlates with the images. The very important differential diagnosis should be made with lunotriquetral instability, and that's the reason why wrist arthroscopy is key to achieve a proper diagnosis in those patients. You see a normal lunotriquetral joint. And also, when we scope the mid-carpal joint, we see that it is quite tight. We cannot find this laxity of the triqueto-Ahmed joint as was described by Lichtman and co-workers, but instead, in fact, we see the laxity of the palmar ulnar carpal ligament and the laxity of the dorsal carpal radiotriquetral ligament. This is the most common finding in this patient. The ligament is not torn. Is simply elongated, probably following a congenital dysfunction or microtraumatic conditions. So, which are the options of treatment for the proximal roll instability as is a consequence of ligament insufficiency, but also we must not forget the neuromuscular control. Most of these cases show up after a prolonged immobilization and the patient lose the neuromuscular control, and that's why develop proximal row instability because they lose the muscular control of the unstable proximal row. Conservative treatment, there are many options. This is the 3-point splint, but we also have some dynamic splints. These ones are very useful for the patient because allow them to train the muscle, and basically muscle training is fundamental. That's the way how to teach the patient how to perform isometric co-contraction of ECU and ECU, also including a contraction of the hypothenar muscle that improve the power of the FCU on the pisiform. We developed this splint, which is an hinge splint that allows that throwing motion in order to preserve the reduce the mobility of the proximal row, as it happens using this splint. And we know that there are some techniques of arthroscopic shrinkage that seems to produce very good results, but we are still concerned, as is currently happening for the arthroscopic shoulder stabilization, in which the thermal shrinkage is mainly abandoned due to the poor results. That was the last proposal by Lichtman, and we tried to reproduce this also by arthroscopy, creating a dorsal ligament plication. Actually, we increased the tension of the dorsal radiotracheal ligament, and also in this way we try to reduce carpal supination by pulling the ulnar part of the proximal row by pulling the radiotracheal ligament. These are the surgical steps. The needle is introduced in the 6R portal. It crosses the ligament attaching on the proximal row. So the grasper is introduced in a mid-carpal ulnar portal, and we shift from radiocarpal to mid-carpal, and then we retrieve the needle to be introduced again into the mid-carpal space, and both extremities of the suture are retrieved from the mid-carpal ulna, and these are tied using a sliding knot to increase this suture. This is what happened by arthroscopy. You see, from radiocarpal, we move the scope in a mid-carpal portal and retrieve the suture from mid-carpal ulna, and then again, by remaining inside the radiocarpal joint, we introduce again the suture around the proximal row. The suture is retrieved here, and then a sliding knot is made. You see, this is the pre-op appearance of the DRC, and this how it looks after repair. You see how tightened it is, and it's strong. It's very good to provide stability. When we have an carpal sag deformity, we associate the procedure of ulnar carpal ligament plication. This is another technique. It can be done percutaneously. It's a very fast and secure procedure. It provides good tightening and also helps the wrist to correct carpal supination by acting on the palmar ligament. So that's the way shown by the video. This is the procedure, very fast. You introduce the needle, then you pass the needle just underneath the ulnar carpal ligament and retrieve these very heavy sutures. You see, it's a 2-0 suture. It's a 2 suture. So the sutures are tightened to create a side-to-side repair. This is the rehabilitation program. You see, we put a lot of stress on proprioceptive rehabilitation, which is started as soon as possible. This is a case. The intra-op evaluation shows the clunk. You see here, and then after repair, the clunk is no more visible. You see after procedure, patient cannot produce the clunk himself. And this is the result after more than 1 year. See no clunking anymore, and then after 5 years, a good reconstruction of the alignment. But we can also have irreparable cases. What can we do? My suggestion is to use a strip of the ECU that can be used to replace the, reproduce the normal orientation of the radiotracheal ligament, and is fixed both at the tracheum and then at the dorsal corner of the radius, helping to reproduce, to block the clunk. You see where the both anchors are located, one here, dorsal aspect, and here. Obviously, we can do a smaller approach, like in a more recent case. But we can also have these mid-carpal instabilities, the proximal row instability, due to a distal avulsion of the radiotracheal ligament, as it happens here. So an anchor can be introduced using the standard arthroscopic portals, and that it can be can produce a good retensioning of the dorsal radiotracheal ligament and blocking the instability of the proximal row. What happens in the dorsal proximal row instability? These are the ligament. This is the concept of the mooring line, and where we should address first is probably the dorsal intercarpal ligament. And this is how we can revise the definition of dorsal midcarpal instability, talking about dorsal proximal row instability, which includes these many different types of instability which were described earlier. This is a typical case, quite difficult to find. Most of the cases, the patient have some kind of mild dizzy rotation, like in this case. Under fluoroscopy, you can show the dislocation, and if you are very lucky, you can see the detachment of the DIC from the dorsal corner of the lunate, and then can be restored using arthroscopy. It's fundamental. You see the large opening between the dorsal lunate and the DIC. You see here, very large. You can introduce a bone anchor, the bride from inside, introduce a bone anchor, and make the sutures using attaching the ligament, which is right there. It can be sutured. This is an all-inside procedure. So this is the X-rays after surgical treatment. What are the future direction? Probably the better understanding of the biomechanics will allow us also to make some tenodesis reconstruction to reinforce the dorsal labrum of the proximal or the mid-carpal joint, and but I believe it's a still long way to go. The different options that we have are very difficult to try all of them because of the scarcity of cases. We have very few cases. The better understanding would allow us to produce a more tailored surgery based on pathological findings, and of course if we can keep the motion preservative procedure, would be better for the patient, just limiting the use of arthrodesis to revision cases of reducible deformities. So what I hope we can agree this afternoon is that the non-dissociative carpal instabilities are a broad spectrum of still poorly understood disorders, and proper understanding is still now complicated by a confusing nomenclature, the poor evidence, and which is due to the paucity of cases. Possibly the definition of proximal row instability would allow for a better addressing the kinematic dysfunction of the proximal row and unify the pathomechanics and clinical approach with the aim to facilitate the choice of appropriate treatment. I thank you for your attention.
What about your technique of mid-carpal application Vora capsule in complete tear?
What about?
Your technique in
Yes.
complete tears? Not only attenuation, but complete tears of the Vora capsule. Is it sufficient?
I don't understand it.
When you have
If you have a complete tear of your
Complete?
tear.
Yes.
Yes. Yes. The most important, before to answer to this question, is to understand that, in fact, probably we don't speak about the same problem. And your take-home message is very important. Because the volar mid-carpal instability, as I described, is a very rare entity, but it exists, because I have seen that. And there is just a rupture of the volar extrinsic ligament, just one mooring line, in fact. And in the case I described, I have never seen detachment of the dorsal part. I have other cases like that with dorsal intercarpal ligament detachment, or what I call with Marc Garcia-Elia the proximal avulsion of radiocarpal ligament, which is, you're right, it's very interesting, and you have, maybe we are just at the beginning of the understanding. And the proximal row instability, you're right, it exists. In my series, in my cases, it's only the volar mid-carpal detachment which lies to the sliding of the second row, and the first row doesn't move, in fact. The first row is still in right position. You understand? It's a little different.
Yes,
and so
it's a wide spectrum. It's a wide spectrum.
Yes, it's a wide spectrum.
And we must be brave and try to suggest these patients an early arthroscopic examination, because most of these patients complain of this dull pain, very stubborn, and there is nothing that can help them to improve and think of proximal row instability.
You're probably right, because I think in some cases, and maybe Lorenzo, you have reviewed the patients, there are some cases with remaining small instability, and maybe it was not only the what I call the rail volar mid-carpal instability, and there is a participation of dorsal ligament too, probably. It's my mistake. I think it's very complicated to understand how it works, really. But on the case I presented, it was the principle is only the detachment of the volar extrinsic capsule ligament at the level of the mid-carpal joint. And with the treatment, with the free suture, I performed the big knot to redress, to restore the normal anatomy. We obtain good fixation. But the real problem is we don't have too much cases. That is the real problem, because it's very complicated, and probably, I don't know if Gustavo is still there.
Yes,
yes.
Because
it will be interesting to have his opinion, and I think it will be interesting now to create a large group, large center analysis following the idea proposed by you and Gustavo. I think it will be very interesting, Lorenzo,
the cases
to
are
go
not
further. Because the principle of the technique is just one point, and probably sometimes I repair one more line and I forgot another one. Probably you're right.
I think diagnosis is very difficult. We will have some questions. Mireia, please.
It's not really a question, but a remark. Yes, I think that patients with proximal carpal row dysfunction are few, and I also think that not all of them need treatment, surgical treatment. So the proximal carpal row instability is only a temporary timeline of the proximal carpal row dysfunction. the instability is clinically defined. It's not kinematically defined. So most of them are lax, most of them are girls, and most of them will never have any problem into their wrist, and they do not need any kind of those wonderful treatment that have been defined here. Only those who start with synovitis, painful synovitis at the triquetrum hamate joint because of the crank, are starting to need any kind of surgical procedure.
Thank you.
This is
Thank you.
So it's not only a proximal carpal row instability, but a proximal carpal row dysfunction, which can live in a clinical instability.
And in these cases, I'm sorry. I have just a question for Mireia. In these cases of non-painful clunk instability, what do you suggest for the patients?
Nothing to protect, to avoid their clunking. They can modify their daily activity.
Do you have any specific rehabilitation protocol to propose?
ECU strengthening.
Okay.
Thank you.
Thank you, Mireia. You have a question for Mireia?
Yes, yeah, absolutely right. In considering a part of the spectrum, because the spectrum is very wide, so the patient that shows up with both clunking wrists and only one is painful just because he stayed with a soft bandage for 3 weeks and it became painful, obviously he has to undergo conservative treatment. I didn't show my slide, I show it very quickly, but 2/3 of my patients are treated by physiotherapy. I don't do nothing. It's a pity because I would like to scope them, to see them inside the joint, how it's not working. And that's why we can try these plication procedures to achieve a tension of those congenitally lax ligaments. But also there are problems following a trauma, like those detachment of the dorsal radiocarpal and the dorsal intercarpal ligament. Okay, these were post-traumatic. So that patient with the DIC detachment was scheduled for a SL reconstruction with tendon graft because it's an early, a young athlete. But in fact, it was the proximal row dysfunction or instability. We have to work out that definition too. And it's very important that we share this knowledge, and we recognize the pathologies more frequently.
But Andrea, in these cases, what kind of exam, pre-op imaging do you recommend? Because it starts to become very difficult to have extrinsic and intrinsic dysfunction in your case, because you had the trauma.
The imaging, I guess that as wrist surgeons, we have to do a great job with the radiologist to agree for evaluation strategy that that can provide reliable results, because the MRIs are done in a very, very different way from place to place, and also arthrography, arthro MRI, they show very bad. You're mentioning
yes,
a fluoroscopy.
I think that it's a dynamic process, so you need a dynamic test, and the fluoroscopy is the best you can do in the radial ulnar in this way.
Yeah.
In your routine practice, do you have dynamic MRI or something?
No, dynamic
fluoroscopy.
Fluoroscopy.
Yes.
Fluoroscopy could be good, but they should be done by the surgeon. So you cannot send that to the radiologist. You should go, and it's most effective if the patient is with brachial plexus with anesthesia.
No, or with a local anesthesia inside, and they do not have the pain, and they do it better.
Yeah.
Gustavo, do you have any comment or any suggestion? What is your experience in mid-carpal instability? Because it's very rare. At least we see.
Well.
Sometimes
I think everything. Yeah, I think everything has already said. I totally agree with Christophe, with Andrea, and with Mireia. The huge advantages we have is that this is a very rare condition, but we have the obligation. We must work in rehabilitation programs, because what Mireia said is very important. Most patients go well just with rehabilitation, so it's very rare to go to surgery. And although images are very important, I think that finally arthroscopy has the last definition when we are inside the surgery, because we have to work on a good examination under arthroscopy of all the intrinsic and the extrinsic ligaments when we have this kind of patients to understand better which ligament is failing. We have to think that this is a true wide spectrum, because we have more than 30 ligaments on the wrist, so we have many combination of patterns. So it's very difficult to put just one kind of instability in a box. It's easier for us to say to do some classifications, to organize the concept, but it's very rare because it's a wide. It's very difficult because it's a wide spectrum. But we should still, as Christophe said, work on this direction to get better concepts for diagnosis and treatment.
Thank you, Gustavo. I think you have some question online.
Yes, we have the pleasure of having Professor Omokawa from Japan asking a question for Andrea about how about the procedure of arthroscopically inserting anchoring screws into the capitate, lunate, and triquetrum to tighten the DIC and the RC ligaments.
Actually, you're great. That's a great analysis of what's going on. Unfortunately, as Gustavo just said, we have 30 ligaments, 20 ligaments, 50 ligaments. Probably we don't know exactly how many ligaments, especially the shape of those ligaments. In the most anatomical dissections, we don't have any attachment of the DIC towards the base of the CMC joint, the base of the metacarpus, so up to the capitate. But if you think that ligament should work to elevate the dorsal lip of the lunate, it should attach somewhere on top. So you're right. Even if we don't have anatomical description supporting your idea, you're very close to a new possibility of treating this function. Recently, I must say that has been published the W arrangement. Elizabeth Haggett published that paper revising the anatomy of the dorsal aspect of the wrist, considering the ligament that spread out from the triquetrum towards the radial aspect of the wrist, which is actually an old concept. It was already described by other anatomists. So from the triquetrum there are three bands. They go towards the distal radius, towards the scaphoid waist, and mostly towards the triquetrum. So probably the most anatomical reconstruction, according to what Professor Omokawa is suggesting, is to reconstruct the band that goes from the lunate to the triquetrum. But it's interesting.
Thank you for the question, Professor Omokawa, and for the answer, Mireia. I'm sure you have a very nice question.
Certainly, perhaps I am less
invasive.
Yes. But if we have a proximal carpal row dysfunction, to stabilize this, we certainly promote a radiolunate arthrodesis, and we avoid to check which is the ligament which is more lax, less lax, and to put the stitches inside and pull there. It has a reliable result, a good functional result, and you maintain your mid-carpal dart throwing motion, and it's easy. And you can do it, of course, through an arthroscopy, but perhaps it's more certain than everything that you are wonderfully explaining, all of you. What do you think about that, please?
I try to be serious, but probably I won't be serious. If the development of the mankind took some 1,000 years to develop the dart throwing motion and the reverse dart throwing motion, why should we destroy the reverse dart throwing motion in a single shot?
But if you stabilize your proximal carpal row, you can maintain both.
But you were proposing to fuse it.
The radiolunate fusion, not the mid-carpal joint. No, I would never promote a four-corner fusion.
Yes, but
yes, a radiolunate
if you fuse the radiolunate, you prevent the reverse.
But it's not so useful.
Not so useful, okay. But you must ask your patient first. And that's right.
Okay.
Told you.
Thank you. Do we have any other question from Spain? Do we have any from Spain? Do we have any question or some remark or something to say? Because you are speaking, you are talking alone.
Yeah. No, I've been talking with Andrea a lot about dorsal mid-carpal instabilities because, as Mireia said, I think it's a dysfunction, and when we think in dysfunction, it's always an instability, and if that instability progresses, there is an overload in the cartilage, and then there is an osteoarthritis. So I think the STT osteoarthritis has a lot to do with dorsal mid-carpal instability or dorsal proximal row instability. So if we talk about this as the function, the first state, laxity, instability, and probably that kind of osteoarthritis is related to this kind of dysfunction. So what do you think about this, Andrea?
Yes, we are increasing our knowledge on these different aspects of wrist pathomechanics. And so I foresee in hopefully a very next future we can find a common ground where we can put the different pathologies in along a unique, a single line that connects them all. So early this morning we discussed at the master course that we don't have the SL dissociation without detachment of the DHC. And probably Sandoz study proposed the very strong value of the long radiolunate ligament, and everything is connected. We must find a way. It is connected. Easy busy.
Yes, if I can add something, step by step, we all agree that the question asked by Mark Ross 5 years ago, we can answer yes. The extrinsic ligaments are the first stabilizer of the carpals. And it is very important because probably we have to think about the change in the treatment of instability. And I love your idea to put an anchor. I do that for the dorsal intercarpal ligament detachment, and try to find the way to stabilize the extrinsic ligament to the bone inside the joint, rather to try to repair the intrinsic ligament. Probably it's a good way for all different instability.
Less effort on the intercarpal ligament and more effort on the extrinsic ligaments.
Thank you. We have Jane.
Excuse me, I would like to ask you an advice because I have a patient that saw recently who has a bilateral mid-carpal instability. On the left side is very mild, and I agree with Maria that we can treat it conservatively, but and is not bothered by this, so we don't touch. But on the right side, he has evident palmar subluxation and on a deviation, and also as he is a pianist, is a musician, he plays 4 hours, 5 hours a day piano. He has in the years the 4th and 5th, he cannot extend the 4th and 5th finger on the deviation when there is the clunk, and so he's completely bothered. In this case, of course, you need to do something because otherwise he has to leave his profession. So, have you seen so severe cases, and what do you suggest?
How old was this guy?
22.
22.
Yeah, he's an hyperlax. He has an hyperlaxity, but on the left side is very mild, but on the right side is really subluxed and no possibility of extension of the 4th and 5th finger.
Yeah, but in this case, I would go through a conservative treatment for at least 6 months, and probably a retraining with this piano teacher. But absolutely, I wouldn't touch this guy. But if I have to touch him, I wouldn't do a radiolunate fusion.
Thank you. Thank you. So medical treatment for the surgery. Nobody has experience in shrinkage, of course, or in the room. Pedro, you have experience in shrinkage? Because
yes,
we are afraid of shrinkage in our unit.
In our first experience with the first cases, we treated using the thermal ablation with shrinkage, only in dorsal with carpal ligaments. And these 3 first patients, they were fine without problem, no complication. Also, many years ago, after the surgery, one of these patients comes again to the office with another problem in another wrist. And I also ask about the all ways that we treated, and yes, it's perfect. No worries. But after our conversation with Andrea, we changed our technique with a dorsal capsulodesis, trying to mix the dorsal aspect of the ligaments, and also our patient is still fine. Now we have treated no more than 12 patients. The 3 first with thermal ablation, the other ones with dorsal precature. But
so you combine
all
the
patients?
shrinkage?
No. The first 3 with dorsal capsulodesis, with thermal shrinkage. The other ones with dorsal capsulodesis with a suture.
And when you perform the
same results. I don't know.
When you perform the thermal shrinkage, it's on the which side? The volar side, everywhere?
No, only in the dorsal side, because it was treated 8 years ago, because we don't have many information about this pathology. But my comment is, it's so difficult to convince a patient that you don't have any problem in your wrist because your ligaments are fine, or you have a laxity, you have another wrist with the same problem without symptoms, and we are going to undergo surgery. But the patient said to me, sorry, doctor, but what will happen in the future if you don't decide to undergo surgery? I don't know. We don't know exactly what is the large follow-up of this patient with or without treatment. Probably nothing.
The only thing we have some concerns about the shrinkage for the some severe side effects or severe complications were described. So you reassure us. The last question, I think, with Alejandro, please.
No, I was commenting that I've done shrinkage with about 4 to 5 weeks of casting in some gymnasts and very lax with pain, but they didn't have this significant clunk. So on exam, they had pain with motion, mid-carpal, and they did very well. But I think that when we have this type of clunk, I think we have a lot to still figure out.
Yes.
But certainly shrinkage can have a role for lesser cases.
Not to abandon this technique. So Thank you. Any other question here in the room? Of course, René Jorquera.
A great lecture, Christophe, Andrea, and Gustavo. I have a little bit question for Christophe and Gustavo, Andrea. And our team, we have a very interesting protocol in the mid-carpal dysfunction symptomatic patient. Okay, this patient, the protocol in rehabilitation. I didn't see in your presentation the evaluation of clinical, evaluation of the rupture of the ligament or incompetence of the ligament, and what do you think the presence of the nerve in treatment in relationship and when mid-carpal instability is real or not real? Nerve in treatment, median nerve in the proximal part of the forearm or radial nerve. We know what the proprioceptive innervation of the carpus is the median and radial nerve, and it's the neuromuscular stabilization of the mid-carpal probably is the same nerves. Okay, what do you think this?
Yeah, so are you making it the other way around? So the problem starts by a muscle paralysis of the muscle control. I never done any EMG or neurological studies on those patients. To put it in a way, I'm trying to reconsider some kind of dystonia, especially in the musicians, because of some mild forms of nerve compression, like the Lacertus syndrome or things like that. But never tried. Can be something.
René, I have never tried, but to recommend a neuromuscular control program, you should see that your ECU is functioning. So you should see that your C8 is correct. Yes, this is to engage in any neuromuscular control of any of their carpal instabilities. Yes. You must be certain that your peripheral nerves are functioning and your muscles are able to control.
Totally agree.
Thank you, Mireia. A very last question because we are very late for the second part. Sorry. Jeff, please.
Yeah, I just wanted to echo what Alejandro said. I think that I would not abandon thermal shrinkage in this setting. I think for the milder cases, I think it's very effective. I do agree that there's a spectrum, and so for the more severe instability with the clunk, it may be less effective. I could share with you my experience, about 10 patients. Many of them improved, and I think it's a lot of debridement of the synovitis, the thermal shrinkage, maybe that provides some denervation effect. But I do think that some of them still had continued clunking. So although it became asymptomatic, it didn't solve the problem. So I think that's a higher grade injury, and I probably would not do it for that. But for the lower grade injury without the active clunk, but with pain, I would not abandon thermal shrinkage for those patients.
Another key issue is how to evaluate these patients. It's not so easy. Satisfaction or loss of pain. Thank you.
So, thank you everyone for the lectures, for the question and everything on this very difficult. So Andrea,
taking my.
So now we will thank you, Gustavo Gomez. You can stay with us, Gustavo. Please don't go.
Thank you, of course,
for the cases discussion.
Thank you, Alan.
So now we will have a second part, short part about proximal scaphoid reconstruction, and I can share my screen, maybe. Okay. So with Jeff and with Ali Habit from Turkey, we will discuss some therapeutic options in proximal scaphoid reconstruction. One of the case is quite controversial with the therapeutic option we choose, and we will have some discussion. So we will start to present the cases, and our attendees just here in the first row will join the debate. And We have Zé, Alejandro, and Luca. So I think we can start now. So for the first case, it is my case. It is about a very young patient. Is a medical student that came to my consultation, handball high level, and he was right-handed. Here is the first surgery he had 3 years before coming to see me. Anterograde screw and through an open dorsal approach. You can see the first x-rays, and when he came to my consultation 3 years after, the main complaint was the pain with at level 7 decreased grip strength, quite conserved range of motion that you can see here. I'm sorry, the patient lives in the Caribbean island, so I couldn't get better MRI than this one, but in the beginning we could see a huge dizzy, the fragmentic proximal pole in this patient, and the main complaint was the pain, and the range of motion was quite good. So the very young patient asked for a second opinion and for a solution. So here is my case. I think we will present all the case, and after we will ask you, just remind the case, we will ask you what do you think about this. Okay, perfect. So the next case, Ali.
Okay, thank you for the organizing committee for this kind invitation to the course, and hello everybody. Firstly, I would like to introduce myself. I am Ali Javit. I am an hand surgeon working in Istanbul, Turkey. And this is my case, 25-year-old male student. He has a history of falling while playing football 5 years ago. Initially diagnosed with a proximal pole fracture, he was first treated with cast immobilization. However, due to non-union during follow-ups, he underwent surgery in another hospital 3 years ago. A non-vascularized bone graft from distal radius was used, and fixation is performed with headless compression screw. And despite surgery, the patient's pain persisted, and he continued to experience limited wrist motion. Consequently, he came to our clinic. And here is the X-rays of the patient. We can see there's a recalcitrant proximal pole non-union and screw inside the scaphoid. We have to remove it. And this is CT scan, coronal scan. Can we move the CT scan, please? Okay, and this is sagittal. And the axial view. So the patient is young. There is a recalcitrant proximal pole non-union. The proximal pole is very small, avascular and sclerotic. There is no radiographic sign of arthritis, and there is a screw. We have to remove it. Sometimes it may not be easy to remove the screw. We may give more harm to proximal pole. We may destroy the proximal pole during screw extraction. So we have to reconstruct the proximal pole. In such a case, what would be your preferred treatment method? Thank you.
Thank you so much, Ali. So now you stay with us, please. Jeff will present a case very similar, and we will discuss after.
Thank you. Yes, it turns out our cases are all very similar, so I'll present a similar case. Again, this is where I'm from. Okay. All right, so this is a patient who presented to me. He's 18 years old. He's a active American football player. For those of you, that's the football where we actually use our hands. I know it doesn't make much intuitive sense, but he's an American football player. He had a proximal pole scaphoid fracture, treated initially with fixation with this screw, and then 5 months postoperatively. Then he came to, at this point, he started developing pain. You see some problem with some lucency around the screw, as well as some possible problem in this proximal pole, potentially with a loosened line here. And at a CT scan at the time reveals there's a non-union at the fracture site, as well as, if you look closely here, you can see the proximal pole is now in 2 separate non-contained fragments.
Thank you, Jeff. So here we faced 3 quite similar cases. The young patients with non-salvageable proximal pole, and they have a conserved range of motion for all the cases. Yes, if we can remind to our attendees, Ali, your patient has all his range of motion and strength. Do you agree?
Yes, no, there is a limitation in the range of motion of my patients in extension and flexion.
In limitation important?
There's a limitation.
Okay, so thank you, Ali. Could you share the screen, please? Okay, so Zé, Alejandro, Luca, you are the attendees of the course, but I think you have some experience in your clinics. What do you think about such cases? Just share with us your opinion, and after maybe we will discuss at the end with the faculty and the experts. Zé.
Thank you.
Can you introduce you, please, yourself?
Zirin here from Singapore, currently fellow with Institut de la Main, IWC in Paris. These are my bosses. So, I think for these 3 are pretty similar cases, very difficult, sort of failed scaphoid non-union reconstruction. I think the general principle is whether do you want to reconstruct the scaphoid, do you want to replace, if you want to replace the scaphoid with a new either autograft or resect them and so on. So if I were to go through the first case, I mean the cause of the pain, which is Alam's case, is probably number 1, I want to rule out, number 1, I want to remove the screw because the screw impingement over the scaphoid fossa could be the cause of pain. And I'm not sure how long has it been, but I need to check whether there's arthritis.
3 years.
So I would remove the screw and assess whether there's any evidence of radiocarpal arthritis, either through the scope or through a mini open procedure. But this is an arthroscopy course, it's going to be a scope. And we're going to remove the screw, check for any evidence of arthritis. If there is arthritis, then it would be some sort of a salvage procedure that I would be thinking of. Yeah.
And in the other cases, so salvage procedure if there is arthritis in my case, in the first case, and in the other cases, the one of Jeff and the one of Ali?
Well, if other cases, if there is no evidence of arthritis, I would still remove the screw and I'll assess the quality of the proximal pole. If the quality is very fragmented, like for example in Dr. Yao's case where it's fragmented, then you kind of have to replace the proximal pole. And probably one of the options is a rib autograft.
Thank you, Zé. We will discuss this after. Alejandro Balzan, could you introduce yourself, please? And thank you.
Alejandro, I'm currently visiting Institut de la Main. I concur also with Dr. Z. Basically, with Dr. Arnaud's case, I think there might be an impingement there because of the screw. I would perfectly take out that screw with the use of fluoroscopy, but also assess myself with the scope view, and also check out if there might be other types of injuries that can be associated with these, and assess myself if there can be an arthritis in the first row, and also look out if there's the biology issue there. I mean, if there's bleeding when I take out the screw, I mean, assess myself in that biological part to see if we need to reconstruct it or maybe just do another type of a procedure.
And if it's not salvageable, if you cannot reconstruct it, what would be your preferred therapeutic option here?
With the vascular grasp, yeah.
Vascularized?
Yeah.
Okay. So from
what type?
Yes, from where?
Matulung.
Okay. Thank you. And Luca, please, could you introduce yourself first?
I'm Lucas from Brazil. And I think that the key for all the cases is the viability of the proximal pole. So if in arthroscopy you see that the proximal pole is viable, you can use vascularized flap or made a free flap if they is even available. The first case, I think that the dizzy, it's a problem because it's very difficult to reconstruct the scaphoid with ligament instability associated. If you use probably I'll use the salvage procedure, and I'll talk to patient if what they prefer, if maintain the strain or maintain the movement. If he prefer maintain the movement, I would do proximal whole carpectomy, and if he preferred to do the strain, I will do a four-corner fusion.
Don't forget the patient is 19 years old, and we have a huge problem with this young age of the patient. For all the patients that are very young.
And in the second case, probably use a free flap, and
which free flap?
Medial condyle. I've tried it, but it's because they're a very small fragment. And okay, that's it.
Thank you. We have another. Any other participants to the course attending who would like to share his opinion, his therapeutic options? No. I think no. So now I think, thank you.
Before we get to the treatment options, in the advanced course, we had a poll about the use of arthroscopy for treating every scaphoid fracture. Anyone in the audience, even the experts, feel this could be treated arthroscopically? No. Yeah? How would you do it, Lorenzo?
Depends. Like Z said, it all depends on what you find cartilage-wise. But if the cartilage is preserved, then you can always try and do a new autograft. And here the problem will be the fixation, because putting the screw back here will be impossible to maintain a good fixation of proximal pole. So in that case, we'll do scaphoid pinning, multiple pinning. To stabilize everything, yeah.
The problem here is that the proximal scaphoid is fragmented. So not only we need to replace the proximal pole, but also we need to manage the cartilage issue. So with the vascularized bone graft, it's quite difficult to manage.
Yeah. The other option is to resect the proximal pole.
Yes, it is an option. It depends on the size after resection of it. Everything depends. Alejandro Badia?
Well, we're all beginning to agree that the importance of the extrinsic ligaments relative to the intercarpal, and I would scope it, I would remove the screw. Hopefully, most of them seem to be on a guide wire, I believe, so you would scope it, flex the wrist, put the guide wire in, remove the screw, and then I would see how much gross motion there is of that fragment. I mean, there was a recent paper that showed removal of these tiny, I think maybe Scott Wolf talked about this, with these tiny proximal poles. I'm wondering if you shelled it out, would the patient still do okay? I mean, they may not have gross instability. You can always do something later if you needed to. The important thing is to get the screw out that's damaging the scaphoid fossa. So
exactly. Yes, exactly. Andrea?
Just a quick comment. I agree with Alex. I would do the same. And I was wondering if anybody here has an experience with using the proximal pole or the hamate to replace that.
This
is the suspense. Okay. We will discuss this later with Jeff.
So no, in my residence, my boss used it 2 times. All the 2 times, the proximal pole hamate become. We need to make another surgery for a salvage procedure because there's no viability with the proximal pole, and then become osteolysis, and then the cartilage become suffered and then collapse.
We need to discuss
maybe
cases. At the end, maybe for the experts, just the attendees. You keep your questions at the end because Maria also. So now we move to the discussion. one will discuss his choice or her choice. For my choice, it's very controversial because we discussed with the mother, with the patients. He was a very young patient. We presented all the possible procedures. He didn't want an invasive procedure because he's a medical student with all his studies, and the sports practice was at the second, was not on the second, was not the main objective of the treatment. So we decided in this young patient to replace the proximal scaphoid with an APSI, the pyrocarbon implant, under arthroscopy. I think you had the surgical technique after removing the screw, of course, and remove here just the surgical procedure. We replaced the proximal pole with an the APSI. We can see here the surgical procedure. The patient went back to his to the Caribbean island, and he was assessed by his surgeon there. 3 years after, he's really happy. His mother too. He's very good regarding the pain. And he came back to the previous level sports. He has a residual stiffness inflection. Here are the last x-rays I could have. And actually, he's very happy for the moment. We had a lot of discussion before using this technique. So before, and why I chose this technique before indicating the pyrocarbon in a young patient, which is really controversial regarding the age of the patients. I asked myself what are the specific problematics for an unsalvageable scaphoid proximal pole. The traditional art salvage procedure are not really optimal, so it is necessary to avoid long-term complications, secondary scapholinate instability. In this case, he has already a dizzy. We need to avoid the evolution to a carpal collapse, to radiocarpal osteoarthritis. We need to consider the cartilage reconstruction, as I told you before, the ligament reconstruction. And when we look at the literature, we will discuss this later. We have the free vascularized femoral bone grafts. We have the option of the proximal hammered grafts, the rib osteochondral graft, and the APSI are the main therapeutic options that are possible. For the free vascularized bone graft, when we look at the literature and when we have some concerns about the site donor morbidity, we will discuss this with Ali Havit, with the technical difficulties and about the residual post-op stiffness, because it is an open and invasive procedure. So we need to discuss this with the patients, and actually in this case the patient was not motivated for this kind of invasive procedure. So we looked at the literature, and I consider also the proximal hammered graft and what we have in the literature. And here my concerns for this patient were the effects on carpal biomechanics and on the ligament reconstruction, and on the low level of evidence, because we don't have many cases that are published in the literature. And as Luca, you have this experience in 2 cases. That's what you told us. So for the moment, I was not very motivated to indicate this in this young patient. And for the rib osteochondral grafts, I don't have experience in this kind of surgeries, and I had concerns about the safety of the technique and also about the learning curve, because I don't have experience. I couldn't do it anyway. I told the patients. So for the APSI, the main concerns are the indication for the young age patient and also for the carpal stability. We had this experience of the unit for Christophe cases of the APSI under arthroscopy. The results were quite good, especially for the pain, and we discussed with Christophe about this indication of pyrocarbon, and finally we proposed to the patient this solution, which is not really a salvage procedure. And we told him maybe if there is any issue after in the mid or the long term, we can replace this APSI. So that that is how we decided the treatment for these patients. So now we will move to Ali Khavit.
Hello again, thank you, Agla. As known, it's an osteochondral-free flap harvested from non-weight-bearing portion of the patellofemoral joint. The osteochondral segment is vascularized by transverse branch of the descending geniculate artery. The technique was first described in 2008, and since then, this technique has been started to be performed for the reconstruction of scaphoid non-unions with distracted proximal pole and advanced stage of Kienberg disease. In the surgical technique, the patient is positioned in spine position under general anesthesia. We perform the surgery under tourniquet. Either side of the knee can be used. It depends on preference. We prefer to harvest the graft from the contralateral knee because we work with two teams and it's more comfortable for us. For the wrist approach, a volar or dorsal approach can be used. It's again based on preference. Our preference is dorsal approach because dorsal approach provides greater ease of visualization of scaphoid fossa and proximal pole. First, subcutaneous veins are formed and prepared for anastomosis. The dorsal branch of radial artery and concomitant veins also found in snuff box and prepared. Depending on the diameter of the veins of the graft, either subcutaneous or concomitant veins can be used for anastomosis. Then the capsule is incised between the second and third compartment. Scaphoid is visualized. Here, in this case, luckily, we can remove the screw without any complication. Then we remove the proximal pole. Its cartilage is not in a good quality and it was fragmented. When removing the proximal pole, it's beneficial to perform a more resection from the distal fragment enough to reach the waist of the scaphoid because creating such a larger defect and larger flap provide us a greater ease of fixation. And we can reach the healthy bone tissue here. Also, an uninterrupted smooth cartilage surface for the articulation with scaphoid fossa can be provided. For the harvesting graft, incision is created starting from the adductor hiatus, moving distally and anteriorly between the midpoint between medial border of the patella and medial femoral condyle. The vastus medialis muscle is retracted anteriorly. The descending geniculate artery can be identified there. The artery is dissected as proximally as its origin from the superficial femoral artery in the adductor canal. The more proximal approach allows us longer pedicle and greater caliber of vessels. During the sections, branch coursing anterior and posterior should be ligated. Ligation and elevation of the pedicle from proximal to distal is performed. At the dissection approach to the trochlea, the dissection should be performed periostally, not to damage the small vessels. Width, length, and depth is required is measured, and the flap is harvested using a saw or osteotome. Then the graft is placed as the pedicle comes to the dorsal part, and the chondral part of the graft faces the scaphoid fossa. In that stage, overstuffing is important. What do we mean with overstuffing? Overstuffing means putting slightly larger graft than the native proximal pole, so the graft fits into the resection cavity. Pat and Higgins, in their study, told that this overstuffing contributes to the carpal stability, and we agree with this idea. Then the graft is fixed with headless compression screw. Can we move the video, please, on the left side? And then after fixation, we check the mobility. Then we do the anastomosis. Again, please video. We check the tourniquet is released and we check the anastomosis. And after closure, you can see the extension and flexion degree of the patient on the right side. I want to show you some of the patient's results that we have done previously. The first patient's man, 42-year-old man with proximal pole non-union. You can see the condition of the proximal pole in CT and MRI. And the 20th month postoperative X-ray union was achieved, and there's no sign of arthritis, no carpal collapse, or no carpal instability here. And the clinical outcome, the there is an acceptable limitation in wrist range of motion compared to the contralateral side. In our experience, the most significant result of this technique is the significant reduction in wrist pain and consequently increase in the grip strength. Therefore, majority of the patients are satisfied with the results with the surgery and don't find this limitation in range of motion to be a great concern. And the second case was a female, 40-year-old female with a proximal pole non-union, very small proximal pole, and the second year postoperative X-rays here. And this patient, the extension is near normal, but there is a more limitation in flexion. However, the patient is very satisfied with the result. As you can see, the improvement in the VAS scores, the pain decreased significantly. And the last case is the 45-year-old female again. It's a revision surgery operated for and recalcitrant scaphoid non-unionist persist. So the 27th mount X-rays. And the clinical outcome, this patient satisfaction is slightly lower because although the pain has decreased, the limitation in extension bothers the patient somewhat. So there are 5 studies with small number of cases and short follow-up in the literature. The longest follow-up was published by Matt and Higgins. They published more than 3 years results. And they operated 41 patients with medial femoral trochlear flap, and 10 patients has a minimum 3 years follow-up. The mean follow-up time was 4 years. Union was achieved in all patients. No carpal collapse was observed. And postoperatively, there is a small limitation in wrist range of motion, but the authors told that it doesn't affect the daily activities of the patients, and the DASH score improves significantly. One patient showed evidence of progression of radioscopoid arthritis, but this patient had a DASH score of 0 3 years after surgery. They have 2 complications, one recipient side complication, one dehiscence, and one donor side complication with ongoing knee pain. If we look at the literature, review the literature, the common point of the studies of the medial femoral condyle grafts, high union rates, improvement in wrist pain and functional subjective outcomes, improvement in grip strength, no carpal collapse, and acceptable wrist range of motion. And when we summarize the advantage of the medial femoral trochlear flap, high union rates were achieved because flap provides 2 important conditions for union. One is biology and the other is stability. Biology because the flap has a good quality of cancellous bone and good and persistent perfusion. And the stability, we can harvest the graft rather big, so we can firmly fix the graft, which improves the stability. And when we have a union, this reflects to the positively on pain and subjective outcomes. The other advantage of the flap is less donor site morbidity. And the disadvantage is technically demanding. Yes, it's technically demanding, but if you are a hand surgeon, you are already familiar with anastomosis, flaps, and so actually it doesn't push you too hard technically. And long operation time, yes, but if you work 2 teams, the operation time decreases. So in conclusion, medial femoral trochlear flap leads to pain relief, good functional subjective outcomes, and high union rates with acceptable motion in the treatment of proximal pole scaphoid non-unions. And the technique in the short and mid-term results shows us that it prevents carpal osteoarthritis and carpal collapse. But still, we need longer follow-ups. Thank you very much.
Thank you so much.
Thank you, Ilham. So I'll present my theory and how I treated this patient, potentially with less morbidity, simpler procedure with longest term follow-up. So we discussed many of the similar options that we discussed earlier. Removal of the proximal pole, I think in this particular case, was the piece was too large, but it does bring up a good point. We discussed just earlier that simple, if it's treat this as a scapholunate avulsion type fracture, maybe just removing a small fleck of the scapholunate ligament and stabilizing the extrinsic ligaments may be a good future treatment option, but that didn't apply in this case because the piece was too large. We discussed salvage procedures. Again, this patient's 18, so we don't want to consider that, especially since there's no evidence of any arthritis at this point. And then we discussed excision plus some sort of interposition, whether it be silastic. We know that that's had problems. Pyrocarbon, at least in the United States, has not been widely accepted. Some tendon, we would be concerned about that, the longevity of that. Scaphoid allograft, I think there's concern for healing potential. And then we discussed the medial femoral trochlear con allograft, which was nicely presented just before. The hamate autograft, as Andrea brought up, and then the rib osteochondral autograft. And for me, at this point in 2023, I think the three bottom options are probably the best options for this particular case. I chose to do the rib osteochondral autograft. I think this is a very useful technique. It's been around for a long time in the plastic surgery literature for nasal reconstruction, also in the knee literature for osteochondral defects. And it's not a new concept. I can't claim credit for this. And Michael Sandow from Australia described it in the 1980s. And so this was our patient. You can see we opened and we saw the piece was in two fragments. They were shriveled up. They were non-reconstructible, so repairing it or reconstructing the native scaphoid was not possible. Remove the piece and you can see there's quite a large void, so simply leaving that alone probably would not have been a good option. And you can see the distal pole, the remaining distal pole had good vascularity to it, so we didn't want to remove the entire scaphoid. So this is the approach, and I accept that people are a little bit intimidated by this. We're not used to operating in the thorax. I get it, but as Javi said, we're hand surgeons, and we can put a finger back on. I think we can approach the rib pretty easily. So this is the seventh rib, a submammary incision. If you feel on yourself, it's very superficial. You can feel the rib directly underneath the skin. And the lower you go, the safer it is in terms of the pleura. But remember, the rib becomes shorter and shorter as you go further down. So that's why the seventh rib is a good compromise. And so you can see a very small incision. You dissect right down to the rib, and you can see there's a nice interface between the rib, which is the red here, and then the costal cartilage, which is the white here. And you just basically take a good segment of both sides. You don't need this much, but for the illustration purposes, we have about 1.5 centimeters of the rib and 1.5 centimeters of the cartilage. Then we basically cut the bone down to about 2 millimeters of bone because you want the osteosynthesis of the remaining rib, the rib to the remaining distal pole of the scaphoid. So that heals to the scaphoid, and the rest of it's cartilage. And it's actually quite fun. You bring out your inner sculptor and you take a little knife and you sculpt the rib till it looks like the size of the proximal pole of the scaphoid. And then once it's fit, I would agree with what was said previously, that you want to make sure you overstuff the joint. I'll get to that more in a moment. You don't want this to be too small. And once it's stabilized, I use the pins in this situation. I think a screw would have a little bit of challenge in terms of fixation within the cartilage. So we pin this. Again, a small sliver of rib will heal to the distal pole of the scaphoid, and this is what it looked like at 2 weeks. And then at the pins are removed at about 6 weeks, and then this is 2 years post-op. And obviously, there's a large void there because the cartilage is radiolucent. And this is a CT scan at 2 years, and you can see, if you use your mind's eye, that the rib has healed to the remaining distal pole. You can even see kind of the transition right about here. And this is the patient 24 months post-op, and he had a successful collegiate football career with excellent strength. And so, again, this is not a new concept. Michael Sandow introduced it in the late 80s. He's published on it a few times. This is one of his papers of 47 patients with 85% good to excellent results at a median 15-month. And he had a poster which, for whatever reason, never got published, but anyway, minimum 10-year follow-up. So the longest follow-up we have on any of these procedures, 40 patients, 90% longevity. So only 10% required further surgery, whether it be a radial styloidectomy or some salvage. So 90% at 10 years is quite good in my book. We had a much more modest cohort of patients, only 3 patients, but with similar results. Minimum 3-year follow-up and 0 complications. The common question is, what do we do with the scapholunate ligament? As we discussed earlier, overstuffing the joint helps maintain the biomechanics. And in fact, Jim Higgins did a study in cadaveric wrist which shows that overstuffing led to maintenance of the carpal alignment. You can repair the remaining scapholunate ligament down to the perichondrium of the rib, but let's be honest, it's not very vascular, so it's not likely to heal. So to summarize, for me, in 2023, I think MFT is a good option. Again, it was presented very nicely. I do think that when we do this, and we do this, 2 teams are preferable. You need to use microsurgical technique. And there is a question of a relatively large incision on the medial knee with persistent knee pain. I do like the proximal pole hamate because it's in the same surgical field. You have the same dorsal utilitarian dorsal central incision. There's often a good size match, but not always, and that's the concern. So you get a CT scan beforehand and make sure the proximal pole of the hamate matches the proximal pole of the scaphoid. If it's not a good size match, you're kind of in trouble. But I do have similar concerns as Alam that we don't know the long-term mid-carpal biomechanics or the implications thereof. So for me, I think this is a very expendable graft. No one misses a nerve. There's minimal to no morbidity. It has the best long-term outcomes. It's an easier approach than you think. It's very superficial. You just need to put a malleable or some other retractor behind the rib as you're harvesting it. So obviously, if you're using an osteotome or a saw, you don't plunge into the pleura. No microsurgical technique is needed, and you might want to consider admitting the patient for an overnight stay just to monitor them if you're worried about the pneumothorax. So, thank you very much.
Thank you. Thank you, Jeff, Ali. So I think we will have some discussions about the therapeutic option we choose. First, Christophe, after the beautiful presentation we had from Ali and from Jeff, what do you think about the APSI indication in this young patient? I did the surgery. It was
the question is really simple. You know, when I started to use pericardal implant, the APSI implant, I always said that every time you can reconstruct the proximal pole, it's always the best solution. And in my theory, I didn't have patients less than 40 years old. But sometimes it doesn't work like that. And of course, at the beginning, I called that a waiting therapeutic option. But now my patient has 24 years of follow-up, 23 years of follow-up, 22 years, 20 years of follow-up without any problem. In one case, I have to change the implant after 20 years. And the patient is good. Just enter and to put the implant. So it's complicated because it works very well. It's 15 minutes of surgery, very simple. You enter arthroscopically, you remove, you put the implant inside, and it works very well. So I understand perfectly the beautiful technique, the Ali's technique is fantastic.
And the results, the outcome, I was surprised by the outcome, especially on the range of motion. I thought
the range of motion is normal. The patient retrieve almost normal range.
They were well operated.
It's complicated to compare beautiful technique, your technique, and Laurent Aubert in France used the same technique for the same indication. But in my opinion, it seems very complicated now for when you have the difference between 15 minutes of surgery and 2 hours or 3 hours, local, regional, outpatient basis, and you need to sleep the patient, I suppose, to remove. So
you need to discuss with the patient, and actually here we discussed with the patient. He had his studies. He was a medical student, and he refused
yes. I understand, but on the principle, theoretically, it's complicated to have a decision. But you're right. The tentative of reconstruction of proximal pole is always the best way. Sometimes it's difficult, and to replace the proximal pole by a rib or vascularized bone graft, why not? But for me, it's a little more complicated.
Thank you for this.
2 questions. So number one, well, 3 questions. Number one, why did it need to be replaced? Number 2, this patient had quite a bit of DC, so is there a concern about that? With just implantation of an implant, there's no way to repair the ligament in that situation. And number 3, when did you let him return to sport?
Why? When?
When?
When? Actually, after it was not the main objective to go back to sports. So after 6 months, he had his study. It was not really an issue. And for the dizzy, I totally understand. But in the alternative therapeutic option, how do you manage if you have such a dizzy in your technique, or in how do you manage the instability and the ligament reconstruction?
Well, in that situation, we would place a larger graft. I love to hear what Ali said, but I would do a larger graft to stabilize that proximal row. It's not ideal, but I just wondered, do you use a larger implant to try to...
It's the same principle for the APSI. It acts like a spacer, and in the space, in the stabilize, it's kind of stabilizer.
So
yeah.
Please don't forget that we discovered, because I didn't know that 20 years ago, but now we know that the primary stabilizer are the extrinsic system. So in fact, we don't touch anything arthroscopically. We make a small approach, you put the implant inside, the extrinsic system is intact. With the spacer, you reduce the disease, false disease of your lunate, and you have a good stability. That is a real surprise, but it's not a surprise, because now we know that the primary stabilizer of the scaphoidate, but not only, are the extrinsic ligament.
So bringing up that point earlier, could we just remove that piece and just imbricate the...
Yes, you're right. But it's better with an implant.
No, but in this case, no. In this case, the piece was a little big. I don't know if you remember. It was not just a partial proximal pole, so it was not possible. Do you have something to say?
Yeah, on that part. 2 years ago, I did more or less the same surgery. I removed the proximal pole to replace with an APSI for the same indication in a young patient, and the APSI dislocated volarly. Maybe it was a surgical mistake, or I don't know, but the APSI dislocated actually in the carpal tunnel. I don't know why. I removed it. I talked to the patient, and we say, okay, let's remove it and do nothing else. But during surgery, I reinforced the extrinsic ligament to stabilize what was left of the scaphoid. Now we're 2 years later, and the patient is fine.
It was the same size of the bone, the proximal bone?
Yeah.
Oh, so it changed the whole discussion of today's session.
Because I removed it, I in the spirit of what we know now, I reinforced the extrinsic to stabilize what was left of the scaphoid. So now he has like a wide gap, scaphoid gap, but he's stable and is
It makes sense to just put the APSI and maybe to remove it after we just because it acts like a spacer, and so there is a constriction of all the capsular structure around. So. Yes, I think we can. There are many options. Yusra.
Just a quick question for Jeff.
Yeah.
If we're not able to radiographically assess healing given the presence of, with a costochondral graft, given the presence of this being basically cartilage, is it really just a clinical assessment? Because there's no X-ray or CT findings that allow us to say union achieved, but rather the patient's pain, range of motion, etc.
No, there was that one slide that showed a CT, because remember, you're taking 2 millimeters of rib. So that's bone, and that's healing to the distal pole of the scaphoid.
So that small sliver of it is what you're looking for.
Is what you're looking for.
Okay.
The coaptation between the rib and the remaining distal pole.
Got it.
The rest of it's cartilage.
Yep.
Yeah.
Got it.
Do we have any? Thank you, Yusra. Do you have any other question from the attendees? No question. Nothing to say. Yes. One question on the right. Could you switch on your mic, please?
Hi. I'm saying, pardon my ignorance. I've never used the proximal pole implant. To prevent this volar subluxation, how do you stabilize it?
The implant, we are supposed in the original technique not to touch and to preserve this palmar capsule. So either there was a previous problem on the volar side, or there was a mistake during the first surgery, but I think it is the first possibility. No mistake during the surgery. Not possible at all. Yeah.
So you just drop the implant inside and that's it?
Yes, because from the outside, and yes, one of the key points of the surgery is really not to touch to the palmar structures. And normally it is auto-stable, and there are many sizes. There is a paper that is published by Mathilde Gras and by Christophe, and there are multiple sizes that are available. So you oversize a little normally the implant. That's what you recommended, Mathilde. Yes, tell us more a little, Mathilde, because you worked a lot on it.
No, you take the smaller size.
The smaller?
Yeah.
And how did you explain, because I don't remember, that with a smaller size there was a stabilization after because of the extrinsic ligaments?
I never knew that.
we are happy we had this session today because we are discovering many things. Thank you for the question.
We discover a lot. Thank you for the question. No, that is a great idea. This implant has been invented by Péquignot, is a French surgeon from Nice, retired for a long time now. And the idea is to have a free implant. And it is very curious arthroscopically when you put the implant, when you enter into the mid-carpal joint, you see your necrotic proximal pole, you remove it. Normally there are 2 or 3 different pieces, it's impossible to reconstruct. When you put the implant fit the place perfectly. It's just amazing. In fact, it's very well designed, but it's just for proximal pole.
From the previous discussions, I understand that if the patient have the previous surgery volarly approach, I'm not supposed to put this implant. Okay, because I know that most of the proximal pole fractures are dealt with dorsally, but in my country, some people are not accustomed to dorsal approach, and they do the surgery from volar approach, and they fix it by K-wires, not by Herbert screw. So it's feasible to do all the grafting and fixation volarly. So if it is the previous surgery from volarly, I should not do this implant. Is this right?
Yes, or reinforce the capsule. But I think in your country, if they use the pins and volary, maybe you have less problem than us, because you can you could see that in the 3 cases it was a dorsal approach and a dorsal screw and a proximal migration in the screw. Maybe we could wonder, wonder if it is a good therapeutic option in the first place. To avoid problems, we need to have the good therapeutic option.
Regarding the other 2 techniques, they can also be done from a volar approach. So the rib graft can be placed volar as well as the MFC. I assume MFT as well. I've only done MFT from the dorsal approach, but MFC is very similar, and you can do it from a volar approach, which is actually sometimes advantageous because it's in the same field as your radial artery, so you can do your anastomosis in that field. Just a quick word about the HAMI, as I know was brought up by Andrea. I have a handful of cases. I think it's a very good option. I mentioned that you have to make sure that the proximal pole is a good size match to the proximal pole of the scaphoid. If it's too small, then you'll run into the problems that we were discussing earlier. I had one patient, however, that it looked perfect on X-ray, perfect on CT. I scoped him again, obviously because he was having a problem. Went back in. I swear the cartilage didn't even look like, you couldn't even find the fracture. It was amazing how well it incorporated. But he still had a problem. We removed the screw, and ultimately required a salvage, a 4-corner fusion. So I'm not entirely sure why it failed. It looked perfect, but the point is that I don't know that we have enough long-term data to really support that at this point. But I think it's a good theoretical option.
Andrea, yes, Andrea.
Sorry.
No, yes, we are.
Which is your favorite fixation? I mean, it's quite tricky how to fix that small piece.
For the hamate?
You use it, yeah, the hamate.
Well, the hamate, it's a relatively large bony piece, so a screw is absolutely fine.
Yeah, but you put have a screw 3.0, 2.7, whatever.
3.0, yeah.
Yeah, those one. Okay.
Thank you, Andrea. Ali, do you have something to add after the great presentation of Jeff? Would you change your mind, or do you have some concerns about the rib graft, or would you go on with your beautiful technique?
Actually, I have concern about non-vascularized graft because I'm not sure about its viability in the follow-up. But thanks to Jeff, he showed us the long-term results. So it can be an option, but I think I will going to do the best I know. So I will continue with my technique, the medial femoral trochlear technique. But if I have FC in our country, I want to try it because it's. I always think that the closed manner, closed approach is always better than open approach. So if we have FC here, probably I will try it.
Thank you so much, Ali. The very last question for Jen.
I'd like to ask to Dr. Kavit if he does, what kind of anastomosis do you do? The terminolateral or terminal, and then how long in your hands the operation lasts with the femoral condyle?
Okay, thank you. I didn't mention, sorry about that. We do end-to-end anastomosis to the dorsal, end-to-end, not end-to-side, to the dorsal branch of the radial artery. And the operation, we work with 2 teams, and the operation took almost 3 hours or 3.5 hours.
Thank you very much.
Thank you, Ali, Gustavo, everyone who are online. And we need to stop now and to end the Seasonal Risk Forum. We thank you to Jeff, everyone, for all the lectures. And just we had this 5 minutes video contest that was launched by Jeanne Messina. And this year we have our winner. It is Mort Hanifa. He used to be in the IWC in Istanbul with Ismail Bülent. And you can, if you want to replay his video, you can go on the IWC YouTube channel. So congratulations to him. For next Seasonal Risk Forum, it will be Lucian Marcovici and Shiab Taleb who will manage the meeting. Maybe they are online, Lucian and Shiab? No, they are not online. Okay. So in between we have many meetings. Please don't miss them. The IWC Symposium, every month we organize this with René Jorqueras, Santiago de Chile, Gustavo Gomez, Buenos Aires, Turkey. It's very interesting. All the young surgeons of our units works on these meetings. Journal Club or cases discussion. You have on the Instagram, LinkedIn, and YouTube all the information to connect and to register. If you want to present a case or something, you are all welcome because it's a real brainstorming meetings. And thank you. See you in a few months.